I'm happy to welcome everyone to this webinar entitled "From Governance Frameworks to Practices of Governance." This webinar is in a series of webinars that we are hosting with friend and sister networks on governance, and that these webinars try to unpack missing links in governance related to how we define governance, how we put frameworks together, how we measure governance, how we assess governance, how we practice governance in the health system. This particular webinar of the series is based on a series of publications in the International Journal of Equity in Health that looks at everyday governance at subnational level. Here we focus on two case studies that were published as part of the series, and these case studies look at decentralization and how it affects health sector planning, and the second one on organizational culture and trust, more specifically at hospital level. The webinar will be moderated by Helen Schneider. An overview of the series will be presented by Lucy Gilson, and then the two case studies will be presented respectively by Benjamin Sofa and Erman Erasmus. We will then leave Helen to moderate an interactive session around these aspects of practices of everyday governance. This webinar is organized in collaboration with two networks, the CHESI and the Resist, and we're very happy to be teaming up with them today for this webinar. Thank you very much to all for being online. Enjoy your session. Don't hesitate to live tweet to let people who cannot be with us online also enjoy the content of the webinar, and I'll be with you at the end of this session.
Thanks very much, Mariam, and welcome to everyone on this webinar. We're delighted to have you as part of this conversation. And Mariam's given a very good introduction, so I don't think I need to say more. And without further ado, I'm going to hand over to Lucy, who will introduce the notion of everyday governance and the series and the approach taken in the series. So over to you, Lucy.
Good afternoon, everybody, and I hope you can hear me. So very pleased to be here this afternoon and to be introducing this seminar. So governance, it's one of those things that we definitely know is important, but it often seems too difficult to tackle, too abstract a concept, perhaps discussions too conceptual, but also perhaps something that only national governments need worry about or should worry about. We started in this work from the understanding that governance isn't something that's too conceptual, something that only national governments should worry about, but rather that governance really is a part of everyday reality, a part of the routines of the health system, just a normal part of management in many ways, and certainly integral to implementing policy change. And we set out to investigate and understand these everyday realities in all the complexity. So the special edition is brings together multiple experiences from different settings to present pieces of work on governance. They're drawn from, in part, a workshop that we organized in April 2016, as well as a wider program of work. And the sort of work that we've conducted has essentially led us and speaks to actions to strengthen governance that come from within the health system, rather than strengthening governance as an externally imposed set of actions, focusing on strengthening accountability between people or leadership practices, and strengthening governance relationship across layers of the system, for example. And our focus in the work that we've done has been with this notion of the everyday practice of decision-making and meaning-making. And in this focus, as we present on this slide, we recognize that others writing and thinking about governance have also recognized that governance is a practice, not just a level of the system or an organogram or a structure. And so we are contributing to that broader terrain of thinking. And in thinking about practice, we've also drawn on a wider body of theory from the field of policy process analysis and policy implementation. So we have worked with this understanding that governance is a practice, not a structure or a national level action only. And the notion of practice that we have used comes from policy analysis thinking, as presented in this particular PowerPoint slide. And this notion of practice directs our attention to understanding that purposeful and effective action is triggered in the everyday, that it isn't necessarily fully rule-bound or even always goal-oriented, and that it requires improvisation, drawing on tacit knowledge, and that practice is taken forward by people, but also influenced by wider social context, social configurations. In the special edition, in the wider terrain of work that we've conducted, we've tried to synthesize some key dimensions in this particular slide. So we have everyday decision-making and sense-making at the heart of our terrain of work. Everyday decision-making that is undertaken by multiple actors drawing on multiple perspectives. Everyday decision-making that is then influenced by a range of social configurations. Rules are part of it, but also important are values, power, knowledge, the histories and cycles of policy change that actors are working within, and of course the broader political and socio-cultural dynamics that they are working within. And in addition, the work that we are presenting addresses issues of policy implementation, accountability, distributed leadership, and leadership spread throughout the system, as well as decentralization. It's really important that in our work, we have to understand that in our work, we've recognized that governance cuts across layers of the system, that that the governance dimensions are multi-layer, governance structures are multi-layer. But we've also particularly focused on actors at the front line of the system, and importantly recognized the role of mid-level managers and their critical place in governance. The range of influences over everyday decision-making and meaning-making also comprise an interaction and a mix of factors that reflect on both the hardware, the software of health systems. And in our work, we've also sought to try and understand the different types of research approaches that offer value for looking at governance in this wide spectrum of issues and these different dimensions. So our special edition is published within the journal International Journal of Equity and Health. So what's relevant in all of this to equity? And here I think we want to emphasize how health inequalities are rooted in inequities and power, as well in the institutional practices of social exclusion, practices that are implemented every day in the routines of the system. So drawing on an editorial from another special edition in this particular journal, we are seeking to understand those soft systems that underpin inequity in the way health systems function and that then underlie health inequalities. And we think that the work that we've done helps to contribute to an understanding of these dimensions of equity. So with that interrupted and slightly brief overview to the overall set of papers in the special edition, we've invited two colleagues to talk to their work. The first is Benjamin Sofa, talking from Kenya, and talking about the experience of radical and significant structural governance change in society and in the health system, and the consequence of that change for the everyday realities of planning and management in the system. And the second speaker will be Ermen Erasmus, talking about the South African experience of the frontline realities of policy implementation, drawing from studies conducted in district hospital settings. Thank you very much.
Let's move to Ermen's presentation, and we need to connect Benjamin, and we'll try to give him instructions offline to connect.
Ermen, over to you.
Okay, thanks, Helen. Good afternoon, everybody. So today I would like to contribute some discussion points from a paper entitled Organizational Culture and Trust as Influences over the Implementation of Equity-Oriented Policy in 2 South African case study hospitals. So this research involved case study work in 2 South African district hospitals. And in terms of the equity-oriented policies, it focused firstly on the Uniform Patient Fee Schedule, or the UPFS, and secondly on the Patient Rights Charter, or the PRC. Basically, the UPFS places patients in certain categories, which then determine how much those patients must pay for their public hospital services. And in a nutshell, the Patient Rights Charter outlines some common service standards or some common behaviors that are expected from patients and providers, and it contains a series of rights and responsibilities that people are supposed to adhere to. In terms of our data collection process, we spent approximately 2 months in each facility. We then took a break for debriefing of field workers, for initial data analysis, and for further planning, and then returned to the facilities for a final 2 months. Our data collection tools included interviews with various stakeholders, observations of facility functioning and policy implementation, as well as 2 structured quantitative surveys. The first was on organizational culture and was derived from the Competing Values Framework, the CVF, and the second survey focused on organizational trust, essentially the trust that hospital staff had in their managers, and was based on the short form of the organizational trust inventory. And just to reiterate, so all of this was about trying to understand something about the influence of organizational culture, organizational trust, street-level bureaucrats, and power, the influences of all those things over the implementation of equity-oriented policy. So just getting to some of the themes that we might want to discuss today. These 2 case studies clearly showed how hospital-level governance can mediate the implementation of national-level policies. We saw clearly how every day, on a day-to-day basis, people exercised power. They built relationships of trust. They broke relationships of trust, and they took all kinds of actions that contributed to the organizational cultures of these workplaces. Often this happened with very little forethought, but nevertheless, all these software influences, all these hard-to-see elements, combined to create unique organizational contexts through which these national policies were filtered in their implementation. Just to give a quick example of what I'm talking about, although not equally so, the organizational cultures in both our hospitals contain quite strong value preferences for order, stability, adherence to rules, as well as competitiveness and the achievement of specific goals. And this resonated quite well with the UPFS, which as a policy was also articulated very clearly. It was articulated in a very detailed way. It was rule bound. It was about categorizing patients into different categories, and then trying to collect fees on the basis of that. And it also came with a provincially determined annual revenue target that these facilities were supposed to reach. So this revenue target played nicely into the cultural elements of competitiveness and goal achievement, in the sense that it was a natural target for these facilities to aim at. However, many of these same characteristics, especially in the second hospital, what we call Hospital B, did not sit very well when it came to the Patient Rights Charter, because the Patient Rights Charter was not as clearly formulated. It could be interpreted in a myriad of different ways, and ultimately it relied on the co-production between the patient and the frontline implementer. So it was very reliant on the discretion ultimately of the frontline implementers, and this hospital therefore struggled to cope with the Patient Rights Charter, because all these characteristics of the policy essentially served to frustrate the order, the control, and the stability that they so desired. So what also came out very clearly from our work was the absolutely key role of how managers governed their facilities or steered the work in their facilities. And this was important in two senses. Firstly, the way that these managers exercised power, the actions that they took, the trust relationships that they maintained, all of this fed back into a general organizational climate. It fed back into levels of organizational trust, levels of organizational culture, which, as I illustrated just now, acted as a filter for the implementation of these national level policies. Secondly, however, the decisions and the actions of the managers were actually crucial for the governance and the steering of specific policies. And perhaps the clearest example from our work in this regard is essentially the rejection of the Patient Rights Charter in Hospital B, or at least the failure to implement it explicitly. And what happened here was that the senior management in this hospital felt that the Patient Rights Charter was too convoluted. It was too open-ended. It was too open to different interpretations, and therefore it was essentially unimplementable. So they elected to try and implement Batupele, which was a similar but different government initiative, essentially setting the Patient Rights Charter to one side. So all of this suggests that even at the subnational level, even at the hospital level, governance is something that has political and strategic dimensions, in the sense that these facility managers have to cope with competing influences, and they have to engage with and try to control and try to manage and try to steer the behavior of various stakeholders in an attempt to achieve policy goals. We therefore concluded that the idea of the subnational manager or the facility manager as a mere administrator or a mere policy implementer was not particularly helpful. It was actually quite limited because they do so much more. So our work suggests that in addition to the hardware elements that they work with, that it's actually important for managers to be aware of these more hard to see things like organizational culture and organizational trust, and that it's important for them to see themselves, but also for others to see them as actors who can act with some autonomy and who have the ability to intervene strategically and in a context-sensitive way in this terrain for two main reasons. The first reason is that not all contexts are equal, or not all contexts are the same. So it's of limited help or limited utility if all the managers act the same, or they act in an increasingly formalistic or rule-bound way, essentially ignoring the different contexts in which they are embedded. And secondly, because not all policies are the same. In our case, the Patient Rights Charter elicited a much more grudging acceptance. It generated more value conflicts. And this suggests that in the governance process, in the steering process, it would be important, for example, to manage the meaning of that policy, to clarify values, to manage actors, to build coalitions and so on. And all of that can only be done if managers are seen as more than mere administrators. And then just finally, changing tack slightly to the issue of methodology, I think we felt that our longitudinal approach, which was set in the real world of implementation and which was attuned to the local setting, certainly helped us to collect rich data and to identify and interpret these hard to see dynamics, but that it did come with certain potential pitfalls, such as respondent fatigue, and that I would argue that this kind of embedded or semi-embedded approach also needs very clear and very strong interpretive and analytical skills and procedures, both because it's the nature of the subject matter. You can't work with organizational trust and culture, for example, if you are not willing to be interpretive in your analysis, but also because this kind of approach generates a mountain of data that you can only successfully process if you are very structured and methodical in the way that you work. Thanks very much.
If you can hear me and if we can hear you, could we have your presentation, please? So, Lucy, I wonder if you would be willing to just speak briefly to this work. And so if at any point you're able to join us, please do.
Okay, I'll do my best. I'm certainly not Tofa, but I'll see if I can at least represent some of his work. So this is, as I said, based on examining the Kenyan experience of radical devolution in a fairly quick period of time, and looking at the consequences for planning and financial management. So the situation in Kenya is a change from what was a fairly centralized system to a devolved system, introduced and instituted by a new constitution in 2010, and creating 47 semi-autonomous counties with the health service delivery function assigned to county governments. And the background to devolution has been the ongoing political contestation within the country around the future of government, the contestation between political parties, and that political contestation led to a very fast-tracked process of devolution in terms of the transfer of functions to counties in a very speedy time. Now, the work that Tofa and his colleagues have undertaken and are still undertaking is based on long-term engagement with county-level managers and what are called sub-county level managers working in one of those 47 new counties. And the work has been implemented through what has come to be called the learning site approach, the idea that by being in the same setting as the colleagues with whom one is working, and having the opportunity for ongoing engagement and inquiry into the experiences, and in fact direct engagement in those experiences. One is constantly learning about the governance events, governance processes that are being carried out in that setting. And in addition, in a learning site, there is a strong emphasis on the co-production of knowledge, that it isn't exclusively the researcher's job to produce the knowledge, but instead that it is through engagement with with health managers that one can better understand the everyday practices of governance, many of which are quite hidden, and so needing to better understand and learn from managers about tacit knowledge and tacit experience. Now, there's a body of work that has been conducted, and Sofa has tried really hard to synthesize that work into a few key bullets, and he would have talked to this in much more detail than I can. But the devolved structures of government after the 2010 and linked to the 2010 Constitution provided counties, the newly established counties that had not existed before, with powers over issues to do with resource allocation and resource use. There is, and there remains, a central level function of resource allocation, but the county level has a significant decision-making power over the resources given to them in terms of how they are used across sectors, for example. But the experience of devolution was that opportunity of county-level decision-making closer to the people than the central level wasn't fully harnessed, and remains something that's being developed because the capacity to make decisions was still very limited in the early days of devolution. There hadn't been clearly established structures, there wasn't a clear delineation of the roles of different players, and there wasn't the full range of technical skills needed at county level to get involved in the everyday realities of financial management and resource allocation. And so one of the key processes of governance that was observed was in fact a re-centralization in some sense to the county level of critical financial management roles, when previously aspects of financial management had been undertaken at hospital level, at district level, which is equivalent really to a sub-county level. After devolution, those authorities were almost re-centralized to the county level, and that led to the taking away of decision-making power from lower levels of the system. And inevitably, the sort of log jams that come with decentralized or with re-centralizing power, the failure to get resources lower down the system, the consequences of that for paying salaries, for ensuring drug availability, and so on. And the re-centralization, as you can see, was from health facilities to the county department, but equally from the health department to the county treasury that had been allocated with the new responsibilities for decision-making around financial management and resource allocation after devolution. So what had been an opportunity for spreading everyday decision-making became an opportunity to hold those powers more centrally at county level, and undermining some of the prior practices of decision-making that had been part of the system. The experience, this is Sofa's last slide, and the experience of being an embedded researcher and of conducting research in an embedded way has also had the real positive value of enabling the collaboration of researchers and managers to feed back their findings into the ongoing processes of both policy development and the strengthening of everyday decision-making. And the slide outlines the ways in which the research findings have been fed back into the ongoing processes of decision-making. So at county level, there's been the processes of engagement with county level managers that have allowed reflection, that have allowed discussion of the challenges being faced, and that has triggered in Kilifi County the development of new legislation to tackle the problems that have developed just after devolution. In addition, the county level experience has been fed back to national level and fed into the development of a range of planning and budgeting tools that are now being spread across all of the 47 counties to strengthen practice at county level, and the development of national health sector leadership and governance policy guidelines to again provide support for county level and sub-county level decision making. And the third thing that the team in Kilifi have been able to do is draw the research and their managerial co-producers into new forms of capacity development within the local setting through a short course for health managers that has been implemented at Pwani University, bringing managers and researchers together to enable a sharing of experience and a distribution, if you like, of that experience to a wider array of managers. So the slide is speaking to the value of an embedded research to governance and seeking to demonstrate the ways in which, through an embedded research approach, one can immediately engage with different levels of the health system and the broader system to, through those forms of engagement, contribute to the strengthening of everyday practice of governance. Thank you, and I apologize, I'm not SOFA, and I hope I've done some service to him.
Thank you very much, Lucy, for stepping in at the last minute. So if you wouldn't mind just giving me a second just to figure out how to unshare my screen and stop sharing. There we are. And I think you can all hear me. Is that right? Yeah. Okay, so what these various inputs have done is introduce the notion of everyday governance, the practice of governance, and an idea of everyday governance is situated in context, local context, national context, social, political, policy context, and really as everyday governance and practices being an interplay between all of those. So what I'd like to now invite is those of you who are on this webinar, and I'm going to endeavour to bring up the list of attendees. If you could raise your hands, let me just try and get to the list. Few attendees. Okay, so if you could apply your minds to what all of this means actually for the agenda of the WHO Collaborative, which is about developing frameworks, strengthening governance, researching governance, and what all of the things we've raised might mean for that. And I see Sylvia Friesendorp has her hand up. Are there Nadesh? Are there? So I'm going to then ask, could someone, can I unmute?
We'll unmute them, Helen. We'll unmute them as you...
Okay, so I'd like to invite Sylvia and Nadesh to make their contributions. And let's see if anyone puts their hands up after that. And maybe we'll take a few inputs, and at some point the panelists might want to respond if there are questions or make comments. So over to you. Could someone unmute Sylvia?
I think I just unmuted myself. Can you hear me?
Perfectly. Thanks, Sylvia.
Oh, okay. All right. Well, thank you for really, despite all the audio glitches, it's really fabulous, and I'm really thrilled to see such so-called soft but really very hard things like culture and trust on the agenda. And I thank the presenters. I have one question for Ermine and one for Sofa. I don't know if you can hear this, but that's actually more of a comment, not a question. I'll start with the last one. It sounded like I was very intrigued by the embedding of the researchers, and it sounded nearly as if they were serving as coaches or as catalysts to get those conversations going that otherwise might not have happened. So this is more of a comment, but that's how I saw that, and I hope we get the slides and can look at them again later. My question to Ermine is, when the data came in from the surveys about trust and organizational culture, was there a consensus about, let's say, well, yeah, we all agree that trust levels are very low, and if so, what did they decide to do about that? And I'll mute myself again for your responses.
Thank you very much, Sylvia. So over to you, Nadesh. I hope, can you unmute yourself, please, and contribute?
Do that for me. Can you hear me?
We can hear you, Nadesh. Go ahead.
Okay, very good. Well, I'll first like to thank the presenters and the organizers for this webinar. I have a question for Lucy and also for Ermine. The first question is with regards to the, I think the framework, the everyday governance framework she presented. And I see from this framework that there are 4 circles: policy implementation, distributed leadership, accountability, and decentralization. And my question is, how did they come up with these elements within the framework? Are these elements findings from the edition, the research, and so that's why they're there, or can that framework include broader elements and not just policy implementation, distributed leadership, accountability, and decentralization? Because from that framework, it seems that those are sort of like elements or functions or aspects of health systems governance. So just to clarify what those elements are and how they got there, and what this means in terms of health systems governance. The other question for Ermine is with regards to the organizational culture and trust. I do understand the difficulty in sort of like researching and understanding these what you call software and hidden aspects, which still play a role in influencing the decisions that managers make within their context. But I would love to have some more clarification on what concretely what those were. What were the organizational culture elements, and how did these work to either confirm or work against the implementation of those 2 policies you mentioned, so the UPFS and the PRC policies? So that's sort of a link between how the organizational culture influenced the implementation or not of those policies. Thank you.
Wonderful. I see Bob Price has put his hand up. Could we unmute Bob? And you could make your input, and then we'll ask Emin and Lucy to respond to that. It seems like Benjamin has disconnected. So we'll ask maybe Lucy to speak to the issue raised to him. Over to you, Bob.
We have unmuted Bob, but he seems to have the same audio connection problem as Benjamin. So not sure we can hear him. Bob, if you want, you can type your question and we'll say it. We'll forward the question to the presenters.
Could we unmute Abdullah Kirchi, please, who's also got their hand up?
Good afternoon. Good afternoon.
Afternoon, we hear you loud and clear.
Oh, thank you. Yes, please. I was just wondering for Mr. Ermin in Kenya, what is, I really was impressed about the level of devolution to the county level from central level, which is a big step and was done with this research element. I was just wondering, is there another level at provincial or even better regional level to handle things at a regional level rather than referring back the loop directly from the local county to the central level, just referring back to the regional level, which is a midway step, which complements this whole effort of decentralization of healthcare services and implementation and governance. I was wondering, what is the situation in Kenya in terms of regionalization of health system? Thank you.
Okay, so thanks to all of those questions. So I'm going to maybe ask Ermin to start with the questions directed at him, and then Lucy. And I see we have another Kenyan participant on the line, and Aaron Mulaki, has offered to talk to some of the questions on their Kenyan experience. So over to you first, Ermin.
Okay, thanks, Helen. In terms of the first question about the culture and the trust surveys and whether there was consensus about what was going on in the facilities, I think consensus is perhaps a too strong a word. I think we try to use these surveys to try and get more than anything else, to try and get a feel of the broad dynamics in the facilities, or the general climate in the facilities. So we didn't spend too much time, for example, testing whether the doctors who answered the survey agreed with the nurses, and whether the nurses agreed with the administrative staff, and so on. But having said that, we did nevertheless, and some of this is addressed in more detail in the paper. We did see some clear patterns in the data. So where there was, for example, quite a high level of agreement or strong agreement with the survey question. So it's not a question of consensus per se, but more of broader dynamics and so on. And if you look at the paper, the most kind of startling difference between the two facilities is, for example, on the extent to which the staff members in Hospital A agreed with various positive behaviors that their managers exhibited. For example, that their managers were reliable, or that their managers negotiated honestly, and so on. And conversely, in Hospital B, there was quite a strong disagreement with all these positive managerial behaviors. And to be honest, I don't really, I don't know. We did present these findings back to the management groups of the hospitals, but I have no real knowledge of what they did with the findings, and whether they did anything different to try and change some of these dynamics. And it's actually interesting. I don't think we we have time now to talk about all the detail, but in some respects the organizational culture and the organizational trust are certainly interlinked, so that it would be for some of these managers, for some of these facilities, it would be quite hard to simply intervene to improve levels of trust, for example, because to some extent the levels of distrust or negative trust dynamics are generated by their organizational cultures and by their management styles in the first place. So they would kind of have to intervene in multiple ways to shift some of these relationships and dynamics meaningfully. In Nadej, so we worked with as I said, with the competing values framework, which basically identifies 4 organizational culture types: the clan type, the developmental type, the hierarchical type, and what they call the rational type. I don't think I have time now to explain all 4 of them in detail, but they differ in the extent to which they are inwardly focused, so focused into the organization, and outwardly focused, and also they differ in the extent to which they value individuality and flexibility and spontaneity versus the valuing control and order and stability. And the way that there are other examples in the paper of the influences of trust and culture, but the way that we approached it was certainly not to say that you can explain everything about the implementation of these policies through the lens of trust or culture. There were other things at play as well, including hardware-related notions of resources or a lack of resources, lack of staff, things like that. But there are other examples in the paper. Just one that comes to mind as I'm talking is an example from the second hospital, Hospital B, where the way in which the facility was managed to a certain extent created trust problems between the managers and the lower level staff. And in this hospital, they appointed a case manager. So this was a person who was supposed to ensure that the nurses filled in all the forms with the treatment, etc., so that patients could be followed up to pay the full amount that they were supposed to pay. And this person encountered a lot of resistance in her work because of a lack of trust. The other nurses said, well, she comes from a different section of the hospital, she doesn't understand them, that it's not their job to fill in forms, they must care for patients, etc., etc. So this person faced a lot of resistance for reasons that had absolutely nothing to do with the UPFS. The nurses had no problem with the UPFS, but the filter or the problems were caused by troubles in the trust relationship. So
okay.
I think I'll end there and hand over to Lucy.
Yeah, I think we need to give. Okay, so apparently Benjamin's on the line. He can tell us how much he's heard of the questions and comments. But Lucy, in the meantime, could you go ahead and speak to the framework and what it represents?
Sure. So thank you for the question. Really, this isn't a framework as in a conceptual framework of what governance is. It's rather a synthesis, a picture of the range of issues that in the set of papers we presented, the range of issues that come out through that set of papers. I think that across the papers we would argue that the the multiple actors, the working across layers of the system, the working with hardware and software, all of those are important. But in terms of the balls of implementation, distributed leadership, accountability, and decentralization, that's just representing the subject matter of the papers that we've presented, and there are other dimensions of governance as well. The key message for governance from this picture is that it is an everyday routine influenced by a range of organizational and social and political processes, and it is spread across the system, not just located at the center. I'll stop there for more time for others.
All right, so I'm going to, could someone unmute Aaron Mulaki, who will say a bit about Kenya, and then we'll hand over straight to Benjamin. I'd ask you to be quite brief, because we've got 15 more minutes for this, and there's another round of inputs we need to take. So, Aaron, over to you.
Good afternoon, everyone. Allow me to respond to the question on regionalization. So the question was whether there was an additional layer in between to be able to sort of filter some of the concerns or policy issues that come from the counties. So historically, Kenya had regions. We had 8 provinces before. And as the constitution was being developed, one of the issues that was raised was the level of bureaucracy that that people had to go through to get their concerns addressed. So we had what we called provincial medical offices that took instructions from the central government and relayed them to the county government, to the districts at the time. So when you look at the spirit of the constitution, the constitution is very heavy on the principle of subsidiarity, where it looks to get the functions to be delivered or implemented by the lowest possible entity that is capable of doing that. So in this respect, then, the issue of regionalization became redundant, and now we have counties. So actually the focus now is less on regionalization and more of ensuring that even counties are able to further decentralize the functions that have been delegated to them under the Constitution.
Thanks, Aaron. So I don't know if, Benjamin, you want to say anything at this stage. I can see now you're unmuted. So over to you if you're able to contribute. Okay, so maybe we will just move on to a few more questions while we sort out Benjamin, try and sort out these
Helen, we have Nonlanha Sumalo.
Yes.
Had raised hand a while ago already, and then we have a typed question from Bob that I can read out after that.
Yeah, so I will send you that next now. Okay, so Bob has typed a question, and we could, but he's also seems to have logged in on a different line. So, but anyway, Bob's question is, regarding the embedding of research, this seems like a powerful government research approach. Can you say what effort has to be made by the researchers to build the level of trust required for this research to take place? Also, looking to the future does, and then he can finish that sentence if he can join us. And I've got then Nonhlanhla Khumalo. I'm going to then ask her if we can, if Bob is not able to unmute or join, we could move straight on to Nonhlanhla, And then we've also got Rubana Islam had their hand up. Yeah, so that's what we've got so far. So, Bob, are you able to join us? Are we able to unmute, Bob?
No.
No, not. Okay. So, Nonhlanhla, let's unmute Nonhlanhla.
Hi, can you hear me?
Yeah, fine.
Yeah. Hi everyone. I just wanted, in terms of Ermin's presentation, it sort of it reminded me of the theory, the street level bureaucrat, and the notion of discretion. And I'm just wondering to what extent, I mean, obviously with discretion influencing people's everyday practices, and how you link that to the concept of governance and governance practices and everyday routines. Hello? Can you hear me?
Yes, we did hear your question. Helen, are you with us?
Sorry, I didn't unmute you. So, Rubana, do you still want to ask a question? Or is
Yes, hi. So I had typed in my question, so it was really about how much, or if there's any, do you think organizational culture and trust is affected by the broader country culture, governance and power relationships among different levels of government and their staff?
Thank you very much for that. So just before I hand over to our panelists, the technology made a comment. Hi, Lucy, I think the notion of everyday governance, software elements are central to governance. We could perhaps borrow from the quality domain, assess the quality of governance, continuous improvement. So it's again that question of how do these notions of governance link to other kinds of notions like street level bureaucracy and quality improvement. So I don't know, Lucy, maybe you would like to start and then we'll move on to Ermin again.
Sure. I'm just trying to see all these things. Gosh, it's quite technological, this, isn't it? So thanks for all the inputs and comments. I think in no particular order, Nonhlanhla, yes, indeed, street level bureaucracy is one of the sources of theory we can draw on in thinking about everyday governance. And in fact, the framework or the picture that we presented in many senses represents aspects of the theory of street level governance. Bob, I've temporarily lost your question, but oh yes, here we are, about embedding of research and also about the funding of embedded research. So I think the Kenyan team are Kenyans based in Kenya, engaged and doing research in the world around them, with prior histories that enabled trust and that were the platform on which the research approach was built, if you like. And so, yes, you definitely need to spend effort in building trust for this type of research, and you need to spend effort in maintaining trust. It's a part of the process of generating rich data, and the process of reflection as embedded researchers is important in the process of validating those rich data. In terms of should it be, how's it funded, if you like, I think the importance is that wherever the funding comes from, there is flexibility in terms of a long-term trajectory, in terms of accepting that the actual research may evolve and change over time depending on the issues that are being thrown up and the types of questions that are being explored. So I think that it's not a question of it should be externally financed or internally financed. It's rather that the pot of funding can be used in ways that evolve over time. And it would be great if countries were able to invest more in health policy and systems research of this type. But there is also going to be a continuing need to rely on external resources, at least for some time. In terms of Rubana's question, I'll leave that one to Ermin. And I just wanted to pick up on Krish's point about action research. And yes, I think that's right, that this type of a focus on everyday governance requires a continuing process of what some would call action research, but we could also call a little bit more loosely action learning, the opportunity of engaging together through processes of doing and reflection that then generate greater understanding and that allow the feedback loop into the continuing processes of decision making. So I'll leave Rubana's for Ermin. Thank you.
Over to you.
Yeah, thank you. Just briefly, I think I agree with you about the notion of street level bureaucracy. I think it was quite an important notion in our work, and it was interesting how in the various examples, the street level bureaucrats exercised their discretion both to support policy implementation and to adhere to policy implementation, and in other instances they exercised their discretion in a different direction to undermine policy implementation or to contravene what seemed to be like fairly fixed and explicit rules contained in the policy. And my gut feeling from our work is that if in those instances where managers had more trusting relationships with street level bureaucrats, where they had better relationships with them, and where they actively managed the meaning of policy so that it wasn't too threatening to street level bureaucrats. So in other words, if they governed in such a way, they were more able to get the street level bureaucrats to buy into organizational goals and to exercise their discretion positively. Rubana, I didn't fully get your question, but I think we didn't explicitly look at the sources of organizational culture, but I would imagine, I think it's definitely influenced by the wider values of a country, because people are also citizens and members of the community in a particular country. I think it's influenced by the broader and very long-standing tradition of hierarchy and bureaucracy. And just thinking off the top of my head, in our cases, I think we have some examples of where culture might have been influenced by long-standing religious values and religious practices, and also by professional backgrounds and traditions, where doctors who are managers, for example, might have different perspectives on how to solve problems, and therefore create different organizational cultures compared to people who have always worked in administration and management and don't have a medical background, who might approach things very differently. So if I heard you correctly, I think I would agree with you that there's a vast number of potential influences on the organizational culture of any particular setting. Thanks.
All right, so I think we're coming now to the end of our webinar. And so from my side, thanks to all of you as participants, thanks to the contributors, a lot of food for thought around questions of embedded research, around the relationship between research and governance strengthening, how local practices influence national contexts and vice versa. Yeah, we hope the conversation continues. I'm going to hand over to Mariam to just make concluding thoughts.
Yes, thank you very much, Helen. Thank you very much, all the presenters. And we're really sorry there was a real connection problem with Benjamin Sofko that we couldn't have him online. But we will try to organize something special with him later on and dedicate it to his work so that we can make up for this loss. And then thank you to all the participants. Again, this time on this webinar, you were a lot of people were with us. We're really happy to be able to connect with you through this webinar series. We will and thanks to Helen also for your moderation, of course. We will put the video of this webinar online very soon. We need a little bit of time for editing it, make it clean, and remove our panic attack of the beginning so that it doesn't go viral. But we will certainly put it online very soon. You will find it on our website, which is hsgovcall, like Health Systems Governance Collaborative.org, hsgovcall. L. But we're happy if it's shared also on the respective website of the networks that have co-organized this webinar with us, JESI and Resist. I think we can also share the links to the publication series that have been at the beginning of this conversation around this webinar series. Thanks to all, and stay tuned for our next webinar sometime in March. Thank you very much, everyone.